Yes, I would think that there is one thing that has, I think may give you false positive is Thylaria. A few species of Thylaria may give some kind of low level of signal, but no, it will be very low. With the PCR, we do not expect that to happen, nor with fish. With the probes we are using, we do have probes that will pick up Thylaria, but we only, for clinical use, we only use probes that are very specific for Babesia. Again, with IFA, there is a possibility that there is some cross reaction, but we do not know to what, because we can only, at this point in time, culture 3 species of Babesia: Microti, Duncani, and Divergence. I mean, Duncani, they can put it in culture, but we can also grow it in hamster. Divergence is the only one currently growing in culture. We are limited. There might be other species which we are not aware of, might be infecting patients, and immunofluorescence assay, IFA, may give some false positive signal to that, but not to known Babesia. We don't think that we see that very often. The Babesia fish is very specific for Babesia. So that's my answer.
Thank you, Dr. Shah.
This is Dr. Barascano. I just read a large series over 13,000 patients that were inquired for doing an EIA, a type of an ELISA for Babesia. And of all those patients, only 2 they called false positives, but one had Lyme disease and the other one had anaplasma. So maybe they were co-infected. In fact, that was part of the conclusion of the study. But otherwise, they did not find any cross-reactivity.
Okay, just so that everybody's aware of, we are working on ImmunoBlots that are going to be more inclusive of Babesia species. And also we'll give answers to this kind of questions where we have an issue about specificity or cross-reactivity. ImmunoBlots, we are working on developing one ImmunoBlot that's going to look at genus, Microti, Duncani at the same time. So hopefully next year we might have better answers, but at this point we don't.
Great. Thanks, Dr. Shah. Mm-hmm. Next is Teresa Esterly. I'm going to allow you to talk. That's the way Zoom phrases it. If you want to ask your questions, it looks like you have a few of them. So you should be able to speak at this point.
Yes. Can you hear me?
Yes.
Yeah, my other question was, what are the best tests to confirm that somebody has been adequately treated for Lyme or the co-infections? I mean, obviously, besides their symptoms improving, I know there's something called the IgXSpot, but I obviously you could look at the PCR in the fish, but what would you all consider the best way to kind of confirm that somebody has been adequately treated?
Okay, I'm going to.
This is Dr. B.
Okay,
yeah, go ahead. Go ahead.
Okay, so basically with the co-infections, we find that the IFA test is very good at monitoring how the patient is doing in most instances. Of course, there are going to be a few exceptions. Say if the patient is positive for ME, the patient will convert to G on treatment, and the levels of antibody do start dropping once the patient has responded. We've noticed that. For Babesia, Ehrlichia, and Anaplasma, we have seen that, and Rickettsia too. But with Lyme, it's very difficult. You do see antibodies going down in most patients, but there are cases of chronic Lyme disease patients where the IgM antibody levels, even though low, are persistent for a long time. With tick-borne relapsing fever, what we have seen is when the patient has responded, in quite a few cases, the antibodies start to disappear. But in the chronic, it has the chronic phase, just like Lyme, where in some patients, we do see IgM persist and even IgG persist for a very long time. So for those, maybe IgXSpot is a good test. Again, with the IgXSpot test, with Lyme, we have more experience. What you've seen is in the late stage, it is sometimes positive in the chronic form of the disease where we can't, the other test fail. So maybe that is another way of following Lyme disease, is to do IgXSpot test. Joe, go ahead.
I was just going to say that, the dogma has always been that there is no test for cure. and you really have to follow the patients clinically. And that includes not just specific testing for the pathogens, but following PET scans, CAT scans, MRIs, SPECT scans actually is more important even. And then, of course, things like CD57, C1q, and C4As, all those different things. But there really is no test for cure. However, I would be really suspicious of persisting infection if any of the tick-borne disease tests remain positive over a period of time.
Great. Thanks, Dr. Joe.
Hi, I'm here.
Thank you for joining us. It looks like you have a couple of questions on your mind. Shoot.
Yes, thank you. Let's see.
I see.
So many. Can you guys just come to my clinic and help me interpret some of these results?
Where are you located?
I'm in the Mid-Hudson Valley of New York.
Maybe we can have a Zoom meeting. I mean, Jyotsna Shah here from IGeneX. We can help you a little bit, but maybe if you want to set up a time with me and we can go through your results and I can just give you my experience of what I think, what I've learned over the years.
Sure. That would be wonderful.
Sure.
Thank you.
So that's something we can do because there is, I can see what's happening here with Bartonella. There's a lot going on with Bartonella right now. So
okay. Yes. Yeah. So that my patient just resulted at the 40 IgG IFA
it's a borderline case. So you don't know, it's sometimes what we are finding with any IFA test at the level of 40, the patient has recovered. It's just lingering antibodies, very low level, or there could be a slight cross reaction to something else. You get that low level signal. What we are finding better than using an IFA test is the Western blots, Bartonella Western blots that we do. We look at 4 species. It gives you a much better picture than an IFA. The other reason you might get a low signal if the patient is having symptoms, it's possible that the patient is infected with another species of Bartonella. So then there's a cross reaction, you see a low signal. Whereas with the Western blots, what it allows us to provide you with is information at the genus level and at 4 species level, Hensley, Quintana, Vincena, and Elizabethae. These are the 4 species we know are causing disease in humans. There are more that we are working on. So that is what I would say when I see a signal like 40. You have, as Joe Bruscano pointed out, you really have to look at the symptoms as well for the patient and go from there.
I don't believe the Western blot's available to New York residents, correct?
No, sure, they're not. I forgot.
Okay.
But can you, okay, there is a way out of it. If the patient can order the test outside New York, that means Connecticut or New Jersey. As long as it doesn't cross the border of New York, we can perform the testing.
Right. Yeah. Okay.
Well, now I think that's the best because they are so busy with COVID. They're not going to review anything for us, even if we send them something. So that might be your option for now.
Thank you. And then how you result the relapsing fever ImmunoBlot when there's an indeterminate that comes in. So that's
Okay,
positively detecting one species,
yes,
but it's listed as an indeterminate result.
Because the way we look to get the best specificity for the ImmunoBlot, we found that when we used 2 bands, our specificity was greater than 99%. I would recommend that if you just got indeterminate to test the patient 1 month later, and probably if the patient has symptoms to treat the patient. But, I can't report it as positive at this point in time because the test is approved with 2 bands, providing the greatest specificity.
Okay, and then I don't know if you can answer this. Maybe Dr. B, you can. In treatment, do you see the relapsing fever responding differently than you might treat one of the other Borrelia species?
Right now, we don't have a clear picture that one species is treated differently than another. Sometimes the symptoms are slightly different, But as far as we can tell right now, we don't really have a handle on different treatments needed for different species. And that's actually one of the many reasons why I'm pushing people to do ImmunoBlots, because you might find over time that, yeah, look at the certain species here requires, for example, a tetracycline rather than a cell wall, or combinations that are different. So right now I don't have an answer, but hopefully collect your data, do a lot of ImmunoBlots, and we'll hopefully find out pretty soon.
Just a point here, Joe. I have read on the CDC site as well now, but in the olden days, relapsing fever was treated with penicillin, and it seemed to work. Now CDC also has put that on their website.
But that's
I'm not a
based on very old
physician. I
data.
don't know, but I'm just,
It's based on very old data. And, most people with relapsing fever, they don't know they have relapsing fever. It's considered to be Lyme disease, and Lyme treatments are given.
Right.
And I've not seen, let's say we have Lyme patients who are not responding to Lyme treatments. I've not seen that these are, in fact, relapsing fever patients who weren't responding to what they were given. Because if they were responding poorly to Lyme treatments, then you'd see a disproportionately large number of relapsing fever patients in the chronic Lyme group. And I'm not seeing that. In fact, the history has been that relapsing fever is more easily treated than Lyme Borrelia. So again, for now, we don't have a clear answer.
Right.
Thank you.
And actually, I'm just going to read a question that relates to what you were just saying, Dr. Joe, from Jessica Mills. And it states, what are your thoughts on treatment when a patient presents with tick-borne relapsing fever?
Well, just like every other tick-borne disease patient, you have to do a full survey to see what other infections they carry, because you want to be sure they don't have, or maybe they do have, co-infections that are important. You also want to make sure that their underlying health, we call that protoplasm, is good. You don't want to hit them with antibiotics if they are full of yeast, for example, have a lot of toxicities. And in my practice, I'd often spend several weeks or longer getting the patients well enough to start the antibiotics. So the first step is a good survey of what you think might be going on in addition to the tick-borne disease, to then look carefully to see what other tick-borne diseases they may carry. And after that, you would begin treatment based on all of that put together.
Excellent. Thank you. I have another question here from Stacy Hahn. It states, how much more sensitive is the ImmunoBlot versus the PCR urine test?
These are two different tests that you are looking at, really speaking. One is looking at the DNA, and DNA can be present for a while. However, the problem with the PCR test is that once you have high levels of antibodies, it doesn't perform well. We have seen that time and time again. In our hands, we find that the test that works well in urine is at the late stage, maybe, or early stage. But when you have high levels of antibodies, it doesn't work. Also, we are finding that the ImmunoBlots are very sensitive because they are looking at multiple species of Borrelia burgdorferi group, whereas the PCR, depending on which system you're using, can be positive or negative depending on your primers and probes. But on the ImmunoBlot, what we have done is we include all the known species that cause disease. So it's more sensitive, not only that we are looking at early and late stage antigens on it. So we are finding it to be very sensitive. Of course, ideally, what I would recommend is doing a panel approach, because some patients may not make good antibodies. In that case, PCR is going to be useful. Urine PCR in our hands works very well. We are finding that, if it's there, we do find it. So a combination of urine and ImmunoBlots is a good idea as well, or doing ImmunoBlots, blood and urine PCR. That's the best. And you get all the answers you need really by doing that.
Great. Thanks, Dr. Shaw. Denise Mudry, I'm going to open up your microphone if you want to ask a question.
Oh, sure, just as my dog starts to bark. My question is, I'm with the Charles E. Holman Morgellons Disease Foundation, and I answer a lot of questions for people writing in, and wanted to know what's the best test for finding out if they have either the Borrelia burgdorferi or the Hermsii.
We have a combo test that we offer, which looks at Lyme, Borrelia, and tick-borne relapsing fever Borrelia group. That would be the best one. Do you want to know the name of the test?
Yes, please.
Okay, LTP1 would be a good one. If you want a full panel, LTP3 would be the best one because it does PCR and Lyme.
MPC?
No, why don't you do this? Send me an email and
Okay.
I will send it to you in writing, okay? And that way you have it.
Yes, that'd be great. Thank you.
Okay.
And I don't know if there's anything on your website that you could have that would have like a Morgellons link that might be helpful for some of them. The email that you had sent to that Cindy Casey got recently on the urine test that you were doing for the 495, I have sent that to several people. Would that not perhaps have been the best one to send them?
No, it isn't really, because it's looking at Lyme. Not only that, you, as I just mentioned, you really are better off doing a panel approach, looking at antibodies and PCR together to get the right answer. And it's important, especially for Morgellons patients, because we are finding, as you very well know, that patients can have Lyme of tick-borne relapsing fever. I mean, in fact, this is where we found tick-borne relapsing fever to be a big Borrelia, to be present in skin biopsies even after a year. That was one of our first cases of tick-borne relapsing fever confirmed by PCR, subsequently by ImmunoBlots as well, on this particular patient that we had found, because on Lyme, the patient always turned out to be negative. And then we have had patients who are positive for Borrelia burgdorferi only, and some patients who are having both. So that is why I think a panel approach for Morgellons patient is very, very important, and looking at PCR and also at ImmunoBlots. And I'll send you the link.
As one of the patients that has both Borrelia.
Yes, I'm not surprised. Just shoot me an email and I'll send you the information, okay?
Okay, great. Thank you, will do.
Thank you, Denise. Thanks for attending. I have another question here. This is probably for Dr. Burrascano. Should you prime the immune system with antimicrobials, herbs, antibiotics before testing?
It's an interesting question that actually was brought up first in the 1990s when the Lyme urine antigen test from IGeneX was very popular, because it was found that antigen spillage actually increased during disease flares, and that also included during Herxheimer reactions. Also around that time, Steve Schutzer, an immunologist, published reports that some people are seronegative because the antibodies that you're trying to measure are bound to antigens in form of immune complex. And that way you get a false negative serology. So it was found that if you treat those patients, the antigen load, in other words, the germ load goes down and the antibodies are now freed up and you get a true positive. Around the same time, I also did a large survey of my own patients and found that people who were seronegative with Lyme, after treatment, 36% of them became seropositive. And those who already had a positive ELISA had a higher titer after treatment, after a number of weeks of treatment. So a number of other clinicians have put this together to try and see if they could increase the yield on these tests. So I think for antibody testing, there is some evidence that a pre-treatment with an antibiotic might help, but we're talking about treatment enough to decrease antigen loads. So it's not just a few days of treatment, but maybe several weeks of treatment, which is also why if you have a borderline or a negative test, you want to wait a month or so, and then you retest it. Now, for direct testing, such as PCR, probably the reverse is true, because antibiotics might inhibit the growth of the germs or start lysing them, and then you will get a false negative DNA test. So depending on the type of test you're doing, that would dictate whether or not you're going to pre-treat. Now, I don't think this is the official policy of the IGeneX lab. This is just me talking as a clinician.
So just to add on the Lyme urine antigen test, I just want everybody to be aware, and we will be talking a little bit more about it. since we have a second generation test, and with times what we've done is now we know there are multiple species of Borrelia burgdorferi that cause the disease. So we have optimized our test to include other antigens that were missing in our original test, because that's what we knew at the time. And it has become very sensitive. Not only that, our tests have improved so much that our specificity has gone way high, greater than 95% for the urine test, where it used to be much lower, about 90. So, and more sensitive, far more sensitive. That's something we are going to talk a little bit more about based on our studies. We have been doing studies on the test to show you how, what we are finding with our newer test in terms of sensitivity and specificity, something to look out for, because we feel that that test needs to come back. It is useful, as Joe pointed out earlier, that we are getting positives in patients that are missed by other tests. Something to think about and look at.
Great. Thanks, Dr. Shaw. I think we have time for maybe one or two more questions. If Kristen Mayhew is still on the line, I'm going to open up your microphone. It looks like you have a question about your son.
Hi there. Thank you so much for taking my question. My son is 14 years old, and in September, he was diagnosed with viral myocarditis. All of the lab work has come back as unknown origin. As a mom, I'm still trying to get to the bottom of what may have caused that. And I was interested to hear what tests you would recommend we do just to rule out the possibility that it was caused by Lyme disease or any other tick-borne illness. And we live in New York, so I know that that limits some of the tests that we're able to have completed. Other than the viral myocarditis, he's a very healthy 14-year-old boy and has not had any other type of symptoms, no joint pain or fever or anything like that.
I can only recommend a panel to do, but that's.
Well, no, obviously the concern with myocarditis is it could be Borrelia. Borrelia is, of the tick-borne diseases, the one most likely to cause a myocarditis. But generally, people at that point do have other symptoms of Lyme. That's not 100% hard and fast rule. Nothing with Lyme disease is. But if you really want to know the way to do it, you need to do two things. One is don't look for just straight Lyme disease. When you get a blood test for Lyme at a large commercial lab, such as Quest or LabCorp, they're testing for one specific strain of one specific species. What you need to do, based on the latest knowledge, is test for a variety of species of Borrelia, both Lyme Borrelia and relapsing fever Borrelia. So role number one is to test for a more broad variety of these tick-borne diseases that are known to affect the heart. And to do that, I would recommend the Lyme and relapsing fever ImmunoBlots. The other thing is there's no one test method that's 100%. And for that reason, what's recommended is you do a series of different types of tests. So for example, I would recommend you add to that PCR testing and look for the direct evidence of the infection that way. I think Dr. Shaw calls this a panel approach, where you're doing different types of methods for the same pathogens. Dr. Shaw?
Yes, that's correct. That's exactly what we do. Look at different markers for the same disease.
And the panel go ahead.
Is there a specific panel that you folks do that you recommend that we do?
Yeah, TBRF 6, that's panel 6. I can send it to, do you want to, I can send it to you.
Okay, so panel 6, yes. Okay. I have the listing of all of them.
Okay, TBRF 6, that's the panel.
Okay, great. Thank you so much. I appreciate your time.
And if you have any questions,
and good luck to you.
Call us.
Thank you. Will do. Thank you very much.
Good luck to you.
Thank you, Kristen.